Okay, good evening, everybody. Welcome to tonight's webinar on professional boundaries. I want to thank everybody for attending at this somewhat late hour. My name is Cara Moroney. I'm the Director of Professional Conduct, and I'm going to be running through the presentation today and explaining the performance expectations outlined in the Professional Boundaries Standard and explaining the nature of the therapeutic client relationship. Just by way of background, for those of you who don't know, I was an investigator at the College of Nurses for 3 years. And I tended to, or I did, investigate pretty much almost all of the sexual abuse cases that came into the college in the last 2 years that I was there, and physical abuse cases, fraud cases, financial abuse, abuse in long-term care facilities, the gamut. So my experience comes from the investigation and disciplinary side, and so I do have a lot of examples where things have unfortunately gone wrong, so I can provide that insight. And then we also have with us Kathie Sharkey, who is a council member and a practitioner here in Toronto, to give some real-life practice examples and also some examples of what she's done to prevent breaches, because that's the most important part of it. So, Kathie, do you want to just give a little bit more about your background?
Sure, thank you, Cara. I've been a kinesiologist for about 16 years, and I've been working mainly in rehabilitation. I work in a fitness facility, and I also visit people with chronic health conditions in their homes. And I'm also the Director of Education for the Women's Fitness Clubs of Canada, where I run courses and workshops for kinesiologists and personal trainers.
Perfect, thank you. And Kathie's two practice settings that she spoke of, the home care and gym, are going to be something that she highlights with her examples, because they can be challenging environments to maintain boundaries because just of the nature of them. And then we also have Ryan Pastana here with us today. He's our communications analyst. He'll be moderating today's session. I'm sure many of you have emailed with him at some point regarding something or other. Just a note, today's session, you will get an automatic certificate that you attended, and you can use it for CPD with quality assurance or any other associations you may be a part of. And please feel free to write in your questions at any point. We will answer them throughout, as well as at the end. If there's any remaining questions, we will try to get to them all. If we don't get to them all, we will contact you afterwards, and there will be an FAQ up after the webinar within the next few weeks. So the slides did go out to everybody. Hopefully you've got them to follow along. So the first slide, just to talk about the standard. It was recently revised to be more clear and concise, and it was circulated to membership for comment. So hopefully you've all had a chance to look over the new standard. It was also revised to cover all aspects of the therapeutic client relationship. In the old standard, it really only talked about things that involved getting too close to the client, like accepting gifts or self-disclosure. It didn't speak to other elements of therapeutic client relationship, like abuse or things like rude communication. So that was amended. And it outlines performance expectations kind of in a bullet point format, and it does that at a minimum level, and so that allows it to be contextual and adapt to different practice settings and to different patients and clients. And also, just by way of intro to start, I just want to really highlight the importance of professional boundaries and that they cannot be understated. The therapeutic client relationship is at the heart of safe and effective and ethical care. And everything else stems from that. And most complaints will originate from a real or perceived lack of professional boundaries. So it's vital that practitioners are aware, that they're vigilant and constantly examining your behaviors with your patients and clients, as well as being aware of how your colleagues manage their boundaries and to help out or say something when you think it's appropriate. Each and every client is different, and understanding their needs can be difficult because boundaries will change depending on client, depending on practice setting. So again, that examining your own behaviors is vitally important, and engaging in self-reflection should help to minimize any of the more significant breaches. I also want to say, we know that you're not perfect, and everybody has a bad day, and especially clients have bad days, and they often can test patience and resolve, but it is your responsibility to maintain those boundaries and to engage in reflective practice. And one of the biggest ways to establish and maintain those boundaries is to involve the client, talk to them about what their needs are, and constantly revisit the treatment plan, what the goals are, what the outcomes have been, and just really involve them in their care is one of the best ways to manage those boundaries. Okay, so the next slide is what is the therapeutic client relationship. So I've mentioned that a few times, and throughout the presentation I might refer to it as the TCR just because it's a little less of a mouthful for me, especially when you're repeating it 25 times. So the TCR, it's a special relationship. It defines the relationship between a practitioner and a patient or client. So the components of that relationship are respect, trust, professional intimacy, and the existence of an inherent power imbalance where the practitioner holds the power in the relationship. And just a note on the professional intimacy, don't get a bit confused by the word intimacy because it's a professional intimacy, and it's because the nature of the relationship is private. It can often be behind closed doors or curtains, and it involves a lot of disclosure on the part of the client about their personal health information, which is some of the most private information we hold about ourselves. And they're also coming to you for help based on your specialized knowledge and skills. So as a regulated health professional, you have an elevated status, and people are coming to you because they trust you to help them get better or stay better or whatnot. And really think of that. You're not, for kins who have been kins for a long time or not a long time, and you're working in maybe a less of a clinical environment, you are now a regulated health professional. You have to hold yourself up to a high standard. I just wanted to also touch on the idea of the power imbalance. Despite what you perceive to be a client's sophistication, the assumption is that the practitioner always holds the power in the relationship. And that's because of the disclosure and the reliance on your skills that creates a vulnerability. The power imbalance can change with context. I mean, you might have more of a power imbalance with someone that's elderly in a home and may have other issues too, other cognitive issues, for instance, as opposed to if you're in a private clinic and you have clients that are teachers, lawyers, like professionals, but it's still there. Don't ever assume that it's not there. So how do you establish the therapeutic client relationship? And just to let you know, there is also the guideline that we have on the therapeutic client relationship, and there's lots of discussion on this subject as well. So one of the basics is proper introductions. Explain who you are, and also ask the client about them, what their history is, why they're there, and even simple things. How do they want to be referred to as? Some people want Mr. and Mrs. or Miss, and other people prefer first names. Explain any policies and procedures of the facility, for example, payment and cancellation policies. Ensuring that you have consent to assessment and treatment, and that is obviously ongoing. Explaining your approach to assessment and treatment, allowing time for questions, allowing time for privacy if needed, and offering the chance to seek another opinion or another option are all methods of establishing a relationship. And then many of the factors that affect the establishment of an effective therapeutic client relationship are things such as age, gender, culture, language spoken or understood, cognitive capacity, mental illness or physical impairments, medical history, and in this way I mean someone has a more complicated history and they're disclosing more private health information, there may be more of a power imbalance, so again that's going to affect the boundaries. History with other practitioners. generally people put a lot of trust into regulated health professionals to help them. But in some instances, you may, especially in the auto insurance world where there might be some litigation going on, you can get clients who are very distrustful from the get-go. You may want to spend extra time with that client to explain your objectivity and explain what your role is and your relationship with the insurance companies and what you're going to be disclosing to them and whatnot, as well as practice settings. And Kathie's going to speak a couple of examples of her practice settings of home care and then at a gym. Kathie?
I think when it comes to boundaries in a fitness facility, it can get a little bit challenging because we're not necessarily behind a closed door. So what we want you to be aware of is the public setting and that you're open to people seeing you working with a client, but they're not meant to ask you questions about that client. So if you have, I have met very many scenarios where I have sisters or husband and wives or friends that are working with me, but if they try to ask a question about the other person, I can't answer. So being aware of those things would be helpful. And in a home setting, when you're visiting people in their houses, obviously being very respectful in their house, but at the same time maintaining your professional boundary. They may want you to have a coffee with them or lunch or something, and they're obviously being very nice and they appreciate you, but you just would respectfully decline and just something like, I had a coffee on my way here, or I have lunch in the car and I'm running out to see another client, but thank you so much for your offer, is a great way to deal with avoiding getting into that kind of gray area of the professional boundaries that you want to stay away from.
And I think actually when we were talking about earlier, Kathie was mentioning when at the gym, sometimes it's as simple as the one person will say, oh, did they come for their appointment today? A practitioner answering that question, it may seem innocuous, oh no, they didn't. But maybe that person was fishing for information because they haven't heard from them in a while or whatnot. You never know the dynamics of going on. So when you've had clients ask you questions about the other person, what do you generally say?
I generally say I'm actually not allowed to answer questions. I have a client practitioner relationship where I can't share anything, I'm sorry, but you can ask her or him when you see them.
Yeah, sometimes I think you have to be very direct with clients. Sometimes there's opportunities to be polite where it's a coffee and it's easy to say, oh, I've had one on the way. Sometimes if it's something like that, you just kind of have to say that you can't do it. It's important to maybe establish that at the beginning so that when you remind them of it, it's just a reminder. And then, if it's something that's persistent, then you might have to just kind of say, you have to explain it to someone a little more clearly. Okay, next slide. Okay, so the next slide is breaches of the therapeutic client relationship. And this can cover a wide range of issues, and they can range from very subtle to extremely overt. And breaches do not just mean getting too close to clients. Those are the cases that are the extreme ones. They're the ones that end up in the magazines on the discipline pages where there's sexual abuse, and they tend to be sensational and famous. But it can also include things such as rudeness or abruptness. That was often a word we saw in complaints, that the practitioner was abrupt with me. It's a bit nebulous, but you have to take into account the client's perspective. It could also be lateness or voicing strong opinions, etc. Now, I mentioned that sometimes these breaches may be perceived by clients, or they can be very, very subtle, and that's why it's the onus of the practitioner to be self-aware and vigilant. Even where it's a perceived breach, the fact is that has affected the client, and that it's affected the efficacy of the therapeutic client relationship. And it's important to be accountable to their perception and to acknowledge that in their mind something went wrong. The other important thing to remember about breaches is that it's very common for the patients and the clients to breach the boundaries. They don't know what the boundaries of the therapeutic client relationship are. They may not even know they're in a therapeutic client relationship in some ways. It's not their onus. It's not their obligation to maintain boundaries. And very many times they push them because they feel close to the practitioner. The practitioner is helping them. And maybe they want to be friends. They're disclosing so much, they want you to disclose something back. But ultimately it will hurt the efficacy. In these situations, it's very important to know how to respond appropriately, and a recommendation that we would make is for practitioners to consider different scenarios and the possibilities, and Kathie will be providing some more. Believing that it won't happen to you is not a good idea, because likely you will have at some point in your career, whether you've been just coming out into this profession or you've been in it for a long time, you probably will experience a client, whether it's something as minor as, well, not that there's anyone minor, but asking you a question, a personal question, to asking you for coffee at their house, from asking you out to a drink, something more overt. It will likely happen to you in some form. So think about those things and be ready for them. A common one is getting requests on Facebook. And we would definitely say that our policy would be to not have clients as your friends on Facebook. Your clients are not your friends. And that's a really important message to get out there to regulated kins. We'll talk more about that later on. If you're having issues with clients trying to breach boundaries, you can always blame the college, blame me, say, you know, the Director of Professional Conduct does not allow me to do this. If you feel like you don't want to hurt the client's feelings, explain what you're doing, explain what the TCR is, and that you have their best interests at heart, and it's important to you to remain objective. From the complaint side, when we get complaints about breaches of the therapeutic client relationship, it's often motivated because the client didn't feel validated or cared for. And we will see a complaint that's about an event. And an example of one complaint that we had at the College of Nurses was the nurse didn't bring the ice chips. And it sounds minor, but really it was because the client was feeling neglected. And you know, so it's really important to recognize that. Now, that doesn't mean that you're going to have an investigation and you're going to go to discipline for that. The ICRC will take the increased complaints and reports committee will take into account what are the reasonable expectations in various practice settings. And so I think Kathie had an example of one client you had where you late.
Yeah, I'll tell you a personal story, but I just wanted to touch on a couple of things that Cara had mentioned. And one is that clients tell you a lot about their personal life. And what happens is you listen. You don't have a judgmental comment about what happened with their husband or their wife the night before. You just kind of listen. And sometimes that leads them to perceive you as a friend. So it's okay to be friendly, but it's not okay to be friends. And you just have to keep that distance. The best thing to do is to just steer the conversation back to your job. So take it back to what you're focusing on, what you're working on, and try to avoid the situation where you're the bartender listening to their issues. Oftentimes what happens is you may be asking clients for a favor if they're a doctor or a real estate agent or something like that, and so that wouldn't be appropriate. That would be crossing the therapeutic client relationship. So making sure that you don't take advantage of things that your clients can offer in terms of work or professional issues. And I will share a personal story with you. I'm not sure how many years ago, but probably about 7 or 8 years ago, so before the college was in existence, I had a client that I was late for a session. I was very late, about half an hour, and it was an issue with one of my children, and a severe medical issue, but that obviously, you know, wasn't a good excuse, and that's okay, because it's not a great excuse. Excuse me, but it does happen. She was very unhappy with the situation, and she really let me have it. I think there were some other issues that were happening. She was not happy about the way her case was being handled. She was in an MBA, and she was not happy with the assessments and the adjusters and her lawyers and anything like that. So I think I was just kind of the go-to for all of her anger. So the best thing to do in that situation when a client is angry with you is apologize and listen. Don't say anything back and just let them have their say and let them vent. It was obvious that she didn't want to work with me again, which was fine. What I did at that point was I called the OKA, and I was put in touch with their lawyer, who was Elise Sunshine. And she gave me some really great advice that I'd like to share with you, and that is to document absolutely everything. So everything that was said, document in your chart. And also, if you were not going to continue the relationship, that it's your onus to provide contact information for other service providers. So that can be done in a letter or an email. You don't have to call the client, but you cannot leave them in limbo. So you have to provide some sort of information to another service provider. You can use the college website with the directory for all of us would be appropriate. So definitely documenting everything and getting a little bit of advice is great. So talking to another colleague or talking to somebody that can be a sounding board for you when something does happen, that's a great way to deal with things.
I'm going to follow up on that story a little bit. And I think Kathie's idea about being friendly but not friends is a really important message. And I like the bartender analogy. Just remember, bartenders aren't regulated under the Regulated Health Professions Act, so different standards. I think what Kathie's story illustrates here is that you'll see on the examples of this slide that consistent lateness for appointments is often seen as a therapeutic breach. You know, a one-off, if that, you know, I can't say what an ICRC would make a decision about a certain complaint. That's not my role. In my experience, having seen many ICRC meetings, if it were being late for one appointment and that person complained, it would likely be a take no action. I feel fairly confident in saying that. However, had Kathie's response been different, had she, you know, not apologized, had she gotten defensive and said, well, my kid was sick, what do you want me to do? Then you have a different story on your hands. And it wouldn't have been a defense for Kathie to say, well, my kid was sick, I was just trying to tell her what was wrong. The approach was not necessary. And sometimes just apologizing to someone who's really irate, even though you feel like you're targeted, is the best thing to do in that moment. Don't be afraid to apologize. There's lots of provinces that are actually passing what we call apology acts because it's shown that if you apologize right away and you're sincere about it, then it actually decreases the amount of litigation. So don't be afraid to apologize. You don't have to apologize in a way that you say you're wrong. Oh, I'm really sorry I did that. But you can say, I'm very sorry I was late and you felt disrespected. There's a bit of a difference there. You're not necessarily saying you did something wrong, but you're acknowledging that they've had a negative experience. And that's a really effective tool to have and to be ready to respond in that way. The other defense that wouldn't be open to Kathie if that had been a complaint is to say that, well, the client was having a bad day and she was mad at all her other practitioners and she just took it out on me. Doesn't matter, again, because the client doesn't owe you the obligation of a therapeutic client relationship and boundaries. It's you that owes that to them. So that's important. So.
Cara, we have a couple questions.
Yeah, I see we have one from Jeanette, and if it's okay, Jeanette, I'm going to leave that question until we get to that part of the presentation. It'll make more sense because we will touch on that. And then we have another question.
The question is, we answered the question about Facebook, and this question refers to LinkedIn. So what if your client wants to connect with you on LinkedIn, a professional network? Is that okay?
LinkedIn is a little bit different because it's not classified as as friends. But again, you could play it safe and just say, as a matter of policy, I don't add clients, because it still could potentially be a window into your life or their life, and still it could also be what happens if you see, because you can see everybody who's connected to everybody. You might then see someone that they're connected to that you want to get in touch with because you think they might help you get another job. And then you go to that client and you say, oh, can you connect me to that person? I've applied for a job at that company. Then that puts the client in a bit of a tricky situation where they feel like the client's supposed to rely on you for help, not the other way around. That one's perhaps a little more contextual, but I'd be very careful with it. And yeah, I mean, for us here, from me here at the college, I do get requests from regulated kins all the time. I don't accept, as a matter of policy, I don't accept that, because for me, if I get a complaint about a registered kin, I have to investigate that, and I don't want to have any sort of, I have to be neutral, so I need to have those boundaries. The best thing to do is maybe just have a yes or no. I don't, and that really keeps it simple. Kathie, I think you kind of you've experienced this a lot, and do you want to tell people what your response is to people?
I think we've chatted about this on and off as well, is that as long as your LinkedIn site is very professional and you're only talking about professional things and you're maybe posting things about health and fitness and things like that, I think that would be looked upon as okay, obviously with some guarding. And I think a professional Facebook page, if it's a business page, like if somebody had a yoga site and they were posting.
Yeah, I think if you have a Facebook page where it's about your business and your clients can be fans of that pages, that might be okay too, because then it becomes a form of advertising, and then as long as you follow the advertising standard, that's, and as long as everything on there abides by that standard, then you should be fine. But certainly I don't know how pages work, but don't be messaging the clients privately. If they post and they're asking you questions, I would be very careful about answering them. If they're asking you clinical questions, you should not be answering those. That's to be done in private appointments. The other thing with LinkedIn, though, is that sometimes you can be part of discussions. I don't know what the access is on that. And, for some people, for LinkedIn, it's supposed to be a forum for having discussions about what's going on in their field. And sometimes it may get a bit political. So also be very careful, because disclosing or voicing strong opinions about something can make a client feel very uncomfortable if they don't hold that same opinion. And they might feel like they have to agree, or it causes discomfort in that relationship, so also be careful about that. But I think, Kathie, you were saying that you have lots of requests for Facebook, so how do you deal with that specifically?
Sorry. Yeah, if a client says, oh, are you on Facebook? Can I friend you? I just politely say I'm not permitted under my college regulations to be friends with my clients, and it's just as simple as that.
Yeah, I think letting people know at the outset, again, prevention's really good. Tell people at the outset, instead of friending them and then having to go back and say, oh, sorry, I can't be friends with you. And again, if that happens, you can always use the college as an excuse, as a way so that you don't feel like you're hurting their feelings personally. But sometimes you have to be a little bit more clinical. You can't be friends with your clients. That's a big message here. Okay, next slide, Ryan. This is just a slide on preventing breaches and repairing the therapeutic client relationship. We've spoken about a lot of these. We've spoken about apologies. Kathie spoke about in her instance she had to assign a new practitioner, or she had to refer someone. One of the ones up here is speaking to someone about a breach or a suspected breach. If you start to think that you have feelings for a client, you like them, just tell someone, get reassigned. It's much better to tell your manager about a breach that hasn't happened than to get caught later on and face the consequences. And I know it's a scary thing, but I'm going to tell you about a case at the end, which is a lot scarier. So really be very self-reflective on that part. And of course, you know, be able to report breaches of other practitioners. Either if it's not a serious breach, it's not a mandatory report, tell the person, bring it to their attention, say, you know, I really don't think you should be talking about your personal life with your clients. And make it about them. Say, you know, because you need to protect yourself if they make a complaint. Instead of maybe saying, you shouldn't be talking about your personal life, that's bad. You want to massage the message and be diplomatic about it, or speak to a manager to have them speak to the person. Don't be blind to it. You also don't want to be in a facility that's having someone investigated and feeling. I've interviewed many nurses of where there was an incident of sexual abuse or even criminal sexual assault, and the guilt that they're plagued with because they didn't know what was going on, or they thought something was a bit awry and they didn't say anything. You don't want to face that. Okay, so the next slide, and I know we have a couple other questions, but I will get to them because they're coming into this part of the presentation, which is about abuse and inappropriate relationships. Okay, so abuse is obviously the worst form of breaching the therapeutic client relationship. I mean, we've talked about breaches of, you know, perhaps, you know, talking about another client or being late or being rude, and that's not necessarily abuse. The overt breaches are often very difficult to repair, if not impossible. Abuse can be subtle, though, and it will depend on the context and things such as, was it repetitive, was there intent behind it, etc. The perspective of the patient-client is very important, although it's not always determinative. There will be some level of what is reasonable. So the example that I told you about, the complaint where the practitioner failed to bring the patient-client ice chips, while they tried to, or they colored it as abuse and neglect, it may not be seen that way. However, if you have a complaint or report about repeated failure to bring a client water, delay in bringing them food, etc., that could be seen as borderline abusive and neglectful. And so the ICRCs will always look at context, things such as the patient-client history, your history, staff-to-patient ratios, practice settings, etc. And then for abuse also, it's obviously has a devastating effects for patient clients. Not only is the efficacy of the TCR affected, but you know, now they're also the victim of abuse. There might be criminal investigations going on at the same time. Practitioners obviously face major consequences, including loss of license for a period of months up to 5 years. 5 years is the most you can get your license revoked by the way. And abuse includes verbal, emotional, physical, neglect, financial, sexual. There's also elder abuse. It's very many things. So just to give you some examples of abuse that I investigated, you know, in long-term care, that's a very common area because you're dealing with clients that are often aggressive. They have dementia and they get confused and they can become abusive. We don't expect any practitioner to be abused by clients, but your response has to be appropriate. It has to be according to what the treatment plan or the policies of the facility are. So some patients will have a treatment plan that says when they get aggressive, call someone or say these words because it's known to calm them down. So you would be expected to know your clients well enough to do that. We had cases where the patient would try to hit them and then that person would grab their arm but hold their arm so hard that there was bruising and hold them down for way too long a period of time, and there would be allegations of really yelling at the client. That's really not appropriate. We also had another case one time where we had a male client and a male nurse, and the male nurse was performing a catheterization, and there was an allegation from the client that you know, he was touched sexually in a way that he didn't like. And there was also a language barrier, so it wasn't clear that he understood what the catheterization process was. And I believe in that case, the nurse was given some advice around making sure that the client does understand the process of catheterization, maybe getting someone else to be there with him, explain it to a family member. But it was not, the information before us was that it was not sexual abuse, that procedure entailed that. So, we're not just going to accept everything a complaint says and go with that. We will look at certainly the context and what's going on. Okay, on to the next slide, inappropriate relationships, which can equal sexual abuse. Inappropriate relationships may not be abuse, but they would be a breach of the therapeutic client relationship. Practitioners must maintain professional distance, and this is to ensure objectivity. This is, again, your obligation. In our guideline, there's a lot of warning signs, examples of warning signs to look out for. So, for example, if you start thinking thoughts about a patient client that are beyond clinical, for example, thinking, well, they looked really good today, spending extra time with a client, booking late appointments, asking and answering personal questions. And a very telling sign is if you aren't willing to discuss the patient client with anybody else. You feel that you want to keep it to yourself. That's often a sign that you shouldn't keep it to yourself and tell someone. I think, Kathie, actually you had a good way of explaining it.
One way that I like to keep things in check and always remember that you are expected to maintain a professional, just a professional, I guess, boundary at all time. Is just imagine that if you had cameras on you, if you were in a reality show, or if you were doing, a segment or something for kinesiology students on a day in the life of kinesiologists. If somebody were to look in on that situation and what you were doing at that moment, would you be comfortable with it being filmed? Would you be comfortable with other people, your family, friends, knowing exactly what you were doing? So kind of keeping that third eye perspective would help as well. We have a few questions that we may want to.
Yeah, and so yeah, that's a very good way of putting it. And I just wanted to, before we answer the question, mark on a couple of the bullet points on the slides that once a blurring begins, it does become more difficult to reestablish boundaries, especially if you're not self-aware. It's not impossible to go back. Again, sometimes you might answer a question one day, someone asks you, like, how's your day? And you're like, oh man, it's so terrible. My kids are driving me crazy. The next time you can go to the client and say, you know what, I want to apologize for the last visit. I was having a stressful day and I didn't want to make you feel like you had to listen to my problems, and then move on to the treatment. Don't let them say, oh, well, it's okay. What, do you want to talk about it? You don't want to talk about it. Focus on the treatment. And again, if you're dealing with some boundary issues, tell someone, get some help. Better to deal with minor ones than serious ones. So we have a question. Someone wanted to give me a hug after an assessment. That's actually, it's a really good question. And that can, again, when I talked about being ready, thinking about a scenario where that might happen, this is a really good scenario. What do you do if someone all of a sudden comes in for a hug? I never hug my doctor or my dentist, my dental hygienist. I don't think that would really, really be appropriate. So, but you don't want to offend the person because then they're going to feel even more vulnerable. So I would not suggest engaging in that hug. If you see it coming, just somehow, kind of maneuver away from it or hold your hand out to shake their hand and say, thank you very much. If it's really unexpected and the person hugs you, I think, keep it short and kind of present and say, oh, you're very welcome. And if it's a one-time assessment and this question is an FAE and you may not be seeing them again, wish them well. If it's in an ongoing relationship, you might even just want to document that so that the next time the client comes in and you're reading the notes before they come in, to recollect, oh, this person might have some boundary issues. They want to get close to me. and be ready for it. Maybe you have a discussion with them or whatnot. I mean, it may not happen again, so you don't necessarily, it may be a one-off, but I definitely would say try to avoid the hug. Kathie might have an answer.
I would also add one thing to that, again, thinking about what it looks like from the outside. If you have a client waiting for their assessment, they're your next client, and they see you hug somebody, and then you don't hug them, they might think they didn't do well in their evaluation or their assessment. So then that goes for any situation in a gym or anything like that. It's not appropriate to hug just because of what the perception is from other people. They might think, well, she doesn't like me as much as she likes other people because I'm not getting a hug. And especially with an evaluation or you know, an FAE or anything like that, it could be interpreted differently from people watching. So I would definitely steer away from that, as Cara says.
Yeah, and I do think that there's ways to kind of try to avoid that from the very beginning. You know, be professional but not overly friendly, because sometimes if that happened to you, I think I would take a step back and look at your behavior and say, was there anything that maybe made the client feel like it was okay to give me a hug? Maybe you're being a little too friendly and familiar with clients, and then they feel that they can put their arm around you or pat you on the back. And maybe you need to rearrange the way you sit with a client. Maybe you're sitting too close to them. Maybe you need to set up a desk area. There's lots of different things you can do to manage that and to really, we don't want you to be robots with your clients. That's not what we're trying to do, but we're just trying to make you really, really aware of the pitfalls of this type of behavior. There's also a question about if a client gives you a business card. You know, if a client gives you a business card, it could be you can take it. You know, I certainly wouldn't use it if they were trying to promote their business, or, you know, maybe you happen to mention, oh, I'm selling my house. That's not necessarily a really personal disclosure. If you're just doing a little bit of small talk, oh, I'm selling my house, and you didn't know that they were a real estate agent. I mean, that's the important thing. If you know they're a real estate agent, I maybe wouldn't mention that, because then they might feel like, oh, I've got to help this person now. But then at the end, if they say, oh, I'm a real estate agent, here's my card, take it. And then, you know, the next time if they say anything about it, oh, you know, you never contacted me, say, well, I got an agent through a family friend. Easy, done. You don't have to worry about it. But you don't necessarily always have to be, oh, I can't take your card, it's not allowed. You can take it and just not do anything with it. Okay, so moving on to, well, we just have there that, you know, I just wanted to bring up that not all inappropriate relationships are sexual. There, you can have close personal relationships that can be seen as a boundary crossing, like becoming friends with someone, because that will affect the objectivity and efficacy of your treatment. And if something goes wrong in the friendship, something might go wrong in the clinical relationship, you open yourself up to complaints. And again, it's just more trouble for you and for the client. Then moving on to sexual abuse, which is obviously, at the end of the day, the worst, really probably the worst form of abuse. But it is often a culmination of little pebbles along the way of someone who didn't manage the boundaries at the beginning. And then it ends up in a relationship. The most common cases are of sexual abuse where the client and the practitioner end up in a sexual or romantic relationship during, or in some cases even after, the therapeutic client relationship. It's very rarely, although there have been cases, and I have investigated cases, where it's a case of an actual sexual assault. And then that's also criminal. So we've had joint investigations with the police and colleges in that regard. But sexual abuse is defined very broadly. It's not sexual assault under the criminal code. And you'll see that even behavioral remarks of a sexual nature can be seen as sexual abuse. And that's very broad as well. So it's not just touching. And also, with that idea of that relationship, it's not going to be a defense for any practitioner to say, yeah, but we got together voluntarily. She she or he consented to this. Because of that power imbalance, the consent is considered invalid. So you can argue it, it won't fly. It absolutely will not fly. So you just, you can't date current clients in any context, regardless of whether you think they're sophisticated enough to consent. Sexual relationships after the termination of the clinical relationship may still constitute sexual abuse if it's deemed that the power imbalance still exists. This is a case-by-case analysis because it depends on many factors. You should always disclose to an appropriate colleague or supervisor if you want to engage in this. Some colleges have some guidelines around this. I know for the College of Nurses, for mental health, in mental health context, they say at least 1 year after the termination of the clinical relationship. Psychologists have a never, because of the nature of the mental health aspect. They say that the power imbalance will always be there, so you're never allowed to date even a former patient client. I don't want to take that approach. Kinesiology is very diverse, and I don't want it to be prescriptive that, oh, you have to wait 6 months and then it's no hold bars. You can go crazy. It depends. It depends on the client. It depends on how long you saw them, what was the nature, how personal were the problems, how much did they tell you. So it's a case-by-case analysis. And there are cases where, you do, and I've people have called me about this. Say, oh, I've been asked out by a client, or I want to ask a client out. I think I have feelings for them. What do I do? The first thing you do is, if you're really serious, end the clinical relationship, tell your manager, and likely wait a period of time. It's not absolutely disbarred that you can never date a former client, but you have to definitely put some measures into place before you do so. But you can never date a current client. It's an absolute. The RHPA is very explicit about having zero tolerance for sexual abuse. Okay, and I'm just going to talk about one of the big cases that I investigated at the College of Nurses. Within the first 6 months that I was there, I was handed this case, and it was a report of termination. The nurse had been terminated because of a sexual relationship with a client. And this case is very interesting. I want to highlight some of the lessons from it. The client had been an in-and-out patient of a facility for about 2 years. And while this nurse wasn't his primary or associate nurse, she had some interactions with him, and she would be involved when the team would have team meetings and case meetings. So she knew who this client was, and the standards of professional boundaries still applied to her with respect to this client. So when we were investigating this case, there were stacks and stacks and stacks of documentation, and I went through it almost line by line. And there were actually a few entries early on where she documented that the client tried to buy her a coffee, and she had a discussion about the TCR with client. And then a couple weeks later, the client tried to bring me flowers. I talked to them about this. And at one point, the unit manager did become aware and talked to the nurse and asked her if she was okay, and she said yes, she was. And then there's nothing after that until about 6 months before our investigation started, where the client started calling the facility and saying that he wanted it out in the open, that they were a couple, that they wanted to get married. He had a ring. Now, this nurse was married, so I don't know how that was going to happen. And at first, the facility actually thought he was making it up. And so they started investigating because they actually wanted to protect this nurse. But then there were clues. They found his belongings with her belongings. They talked to the client's mother, and the client's mother had been in contact with this nurse, and it wasn't because she was calling for clinical reasons. I think she had been to the house. And they called the nurse in, and there was some other level of proof there as well that they were having sexual intercourse, and the member admitted to this and was fired, and then it came to us, and we did a very, very thorough investigation. And it ended in a 5-year revocation for this nurse and an oral reprimand in front of the discipline committee. But it also, during the investigation, the client committed suicide. I remember, the mother was obviously very distraught over this. There was fears of litigation against the facility. The facility itself was very rocked. I remember interviewing many managers and staff members that said, of all nurses, and not that you want to think any practitioner would do that, they said of any nurse, this was the last person we'd suspect, that she had been exceptionally good at managing her boundaries. She wasn't new to the profession. She was about, 10 years practicing. And, and obviously her own personal relationships were probably affected by this. So I raise this case because while it's an extreme case, there's a lot of lessons to be taken from this. And one is that boundary violations are often initiated by a client. So be ready and be prepared. Two, that boundary violations often start off small. It starts off with maybe a coffee or maybe flowers and maybe talking to the client a little bit more, and then becoming secretive later on. And three, that don't be secretive and don't think that you can handle it. Tell someone. Even though there was some evidence that the unit manager knew at some point, it was never really dealt with after that, and she never indicated a problem after that. She likely would have been reassigned. As a supervisor, if you're in a supervisory role and you become aware of anything like this, take it seriously and investigate, and don't necessarily just accept that the practitioner says, no, okay, I'm fine. Take the initiative and say, well, I'm going to reassign you just to be safe. I'm going to protect you and the client. That it can happen even to the best practitioners who normally exhibit good boundary management. Six, that it's often more common where there's ongoing treatment and where the client has the opportunity to constantly persist by pushing those boundaries and wears a practitioner down. And lastly, that there are disastrous consequences beyond just the technical, you lose your license. I mean, for all intents and purposes, lives were destroyed in this case. And again, don't think it can't happen to you. I think that's a really important message, and be prepared for this might happen. Okay. I think we had a question though about a friend. Can you become friends with a client?
I think there was a question.
How
long?
Yeah, so we have a question here. How long after you have discharged a client is it okay to become friends with them? I would say that same rule applies. I mean, it wouldn't, if it's just a friend and it's platonic, it's not going to be a sexual abuse type of scenario. So it doesn't necessarily fall technically under those rules. And but you want to be careful, because what if they do come back to you as a client once upon a time or whatnot? And actually, so there's not necessarily a rule about that so much, because it may not be, or as long as it's not sexual abuse. But it kind of leads into the next and last slide, which is on treating spouses, and I'll explain why at the very end. Under the current legislation, treating spouses is considered sexual abuse. Now, this may be changing, and several colleges are passing regulations to exempt this, and we will be looking into this at our college, and the membership will be consulted about the progression of this matter, but it's kind of beyond the scope. But regardless of any regulations, I did want to point out that because spousal and also family relationships are by definition not characterized by professional distance and boundaries, it's hard to maintain objectivity. So the relationships are almost inherently contradictory. And it's really hard to go from, okay, I'm your kinesiologist now, and now I'm to your friend. So even if we do pass a regulation that exempts it from being sexual abuse, the recommendation of the college is do not treat your spouses or your family members. And going back to that friends question, if you look at the guideline, the word family member is defined very broadly to include any close personal relationship. So if you become friends with an ex-client, you'd have to be very careful never to treat them again, because you've lost your objectivity. Now they're a friend. So that's on that one. Are there any? We're just going to see if there's any further questions, but we're almost out of time.
So the question about a current friend is coming to you for treatment, I think Cara pretty much answered that question, is that it's a blur between the therapeutic patient relationship, because when they come to you as a client or a patient, you have to uphold your standards, and you have that inherent power imbalance on your side. So ideally, you're not treating friends, or you're not treating friends.
Yeah, I mean, because when we were talking about how you are with clients, when we said you can be friendly but not friends, that would kind of be contradictory. So again, if someone comes home and I hurt my shoulder in volleyball ice, that, we're not going to get up in arms about putting ice on something. And you can say, well, elevate, and then just recommend, go see someone. You can recommend someone that's fine, but don't get into ongoing treatment. It's a very dicey situation. If we had time, I'd tell you the famous chiropractor case, but you might know about it anyways, but I can maybe put it in our FAQ. I can link to it.
Do we have time for a couple more questions? We have a couple good ones. Yeah. So we had a question that there's understanding that accepting gifts is not permitted, but how about giving gifts is not permitted, even token?
No. I mean, again, it's just sometimes it's easier to just say no. I don't see a situation where a practitioner would ever be giving something to a client. I've never received anything from a doctor or a nurse.
What if it's like a water bottle with your business name on it?
Oh, yeah, that's a little bit different, but that's not a gift. I mean, it's like the dentist, when you go to the dentist and they give you a toothbrush, but that is something that is done with every client every time. It's not personal to a particular client. Okay. So if it's promotional or it's something like a toothbrush that is not controversial, that might be okay. And with gifts, I just wanted to add, because that was one of our FAQs at the end of the session, although people have asked so many good questions that I didn't need to use them. It's accepting gifts. If someone comes in with a gift basket or a box of chocolates or maybe even a homemade casserole or something, what you can do is, what we advise to say is, oh, thank you very much. This is so kind. And, we can't accept personal gifts, but I'm certainly going to share this with the rest of the team. If you're a sole practitioner, it might be a little different, and you might have to be careful of that. But if it's a token, if it's not a very personal, if you are part of a team, say you're going to share it with the team. But if it is personal, or if it's expensive, I would not accept it. That's going to just really, again, confuse those boundaries. And you might also want to take a step back and examine, why is the client giving me this? Have I given off signs? I mean, some people might give a $600 watch to their practitioner and not think anything of it. But, as much as I earlier said it's not the duty of clients to maintain boundaries, I think a lot of clients would realize they're not expected to give people personal or expensive gifts. So if they are doing that, has there already been some blurring that has been occurring, and maybe take a step back, and then not accepting the gift might be a good opportunity to repair if there has been some blurring going on. But certainly that's with giving gifts. We have another follow-up question. Can you receive a small gift at Christmas time? Again, if it's a small gift, I'm not sure if there was a specific example. Again, if it's a small box of chocolates, again, just say, oh, thank you very much. I'm going to share this with the team. And you can always use your facility. Say, oh, the facility has a policy of not receiving gifts, but I will accept this and share it with the team. If it's something that can't be shared, I guess a mug you could keep at the facility. If it's a small gift that's particular to you, I think it might be best to decline and explain why very politely. Because if you accept it, I think a lot of people are scared that they're going to get the complaint or they're going to get the client upset because they don't accept the gift, but you have to take that step back and realize, well, what are the possible consequences if I do accept the gift? Is that going to start to blur the boundaries? What if they come next week and give me another gift or another holiday and it gets bigger and bigger, than they expect that their rates should go down because they're giving me gifts and this stuff. So, sometimes you have to be, you might have to risk a little bit of discomfort and a feeling of rigidity with a client, because again, it starts out small, and it can end up much worse. So I just always advise an abundance of caution. The example was like homemade jam. Jam you can share with the rest of the team. So put it in the communal fridge and tell everyone there's homemade jam. So those are great questions, and we're going to have to sign off now. It's just 8:01, and most people probably want to get back to their lives. And we will, if there's any questions that I haven't answered, I will definitely get in contact with everyone. So thank you for attending. You will receive your certificates in the next few days. And again, if you have any questions, feel free to contact me. And I really, I think coming to this webinar is really commendable for everybody, because it's really, really important. And when you're talking to other professionals about this that haven't been here, talk to them about boundaries, about how important they are, and tactics you can use to deal with them. So I want to thank everyone for coming tonight.